on our Washington State Department of Health team, and I'm going to be talking about skin and soft tissue infections. So here's a flow diagram on how you may consider categorizing skin and soft tissue infections or cellulitis. We're going to get into purulent and non-purulent cellulitis, but we don't have time to talk about necrotizing infections. So we're going to focus mainly on the ones you see here. So let's, before we dive in, it's important to think about context when we are discussing cellulitis. And that if we step back, think about our host. So is this an immunocompromised person or immunocompetent? The location on the body that we're dealing with is going to tell you a lot about the different kind of organisms that might be causing a skin and soft tissue infection, but really there are two main ones that I'm going to talk about. And then also the environment or their exposures make a difference. For example, a burn wound is going to be very different from some of the examples I'm going to show you. Or if somebody was in the ocean or salt water, there's a whole different group of organisms we're going to worry about. Same with bites and scratches. We're not going to get into all those esoteric and miscellaneous types of infections because the sky's the limit on that. But we're really going to just focus on the main kind of the main pus producing or not. And then when we say cellulitis, we kind of say, that's skin in general, but the layer of the skin makes a difference too. And that's how we ultimately categorize some of the cellulitis diagnoses. So if we talk about purulent or pus-forming infections first, this can be subdivided into a singular abscess, or like one big pus pocket, or purulent cellulitis, where it's not all just one pocket. So let's look at an example. So this female reports a quote-unquote spider bite that started as a pinching pain, but now has grown increasingly red, swollen, and painful. What bacteria is responsible? As you can see here, Staphylococcus aureus is the #1 culprit for pus-producing skin and soft tissue infections or abscesses. And very often people think of these as spider bites for whatever reason, and that's the presentation. And in honesty, there is often a little crust or crater involved, and that may be where the pus started to drain out or where people were picking at it, and that often gives the illusion of maybe that was a bite. And Staph aureus is a gram-positive cocci, so if you were to look under a microscope, this is what you might see, these purple clusters that are circular. So I showed you an example of a single abscess, but as you have probably seen, there can be different ways this presents. And so examples are folliculitis, and that is where the hair follicle, a singular hair follicle is infected, and you may only see it where the hair follicle is originating. As that infection progresses, it gets deeper. And so you can kind of see here these white blood cells going down to the length of the hair shaft. That will make a larger kind of quote unquote bump and maybe more painful. It's called a furuncle. And then when it clusters, so you see a bunch of these hair follicles infected, and now it's kind of involving its neighbors. This will be even larger and kind of a bumpy pus pocket may be forming on the surface. And larger ones that involve multiple hair follicles would be a carbuncle. So let's look at another similar case. So this male developed a lower extremity abscess. The provider sees them, does an appropriate incision and drainage. The next question is, first of all, do they need antibiotics? And what would be the appropriate antibiotic choice? So for the sake of argument, let's say this person does need antibiotics. You want to just take a moment to think about what you might prescribe. I'll advance. So again, because we're dealing with Staph aureus, most likely because there's pus production, and in adults, it's very common that it's MRSA. We want a MRSA covering antibiotic. So let's discuss this a little bit more in depth. So for abscesses, what is the role of antibiotics? For many that are very small, you may not need antibiotics at all. So when do you need it? So there were two randomized controlled trials in 2016 and 2017 that looked at small to medium-sized abscesses. So the DOM 2017 here looked at 5 centimeters or smaller, whereas Talon and investigators looked at skin abscesses that were at least greater than 2 centimeters. So we're looking in that 2 to 5 centimeter range here. They looked at ED patients, and it was adults and kids, and they with an abscess, they all got appropriate incision and drainage. And then they were randomized to an antibiotic versus placebo. So the one on the left here, they randomized to clindamycin versus trimethoprim sulfamethoxazole or Bactrim versus placebo, whereas the other study looked at Bactrim versus placebo alone. And what you could see here is they looked at clinical cure within after 1 week, and they found that there was better clinical cure with those who did receive antibiotics. So the summary or take home from these was that for a simple abscess, it was greater than 2 centimeters, incision and drainage with antibiotics resulted in clinical cure at 1 to 2 weeks. So what about the organism causing the abscess? How do we determine which antibiotic we need to use? So in both of these studies, they cultured that pus and to find out what was the causative organism. The vast majority here, you can see almost 50% in both of these grew MRSA. And now this was a combination of adults and kids, but adults are going to be more likely to have MRSA, whereas kids depends on your local antibiogram and very much importantly, their personal history. But in some communities and some patient groups, MSSA may be more common, again, the pediatric groups. Regardless, you can see nearly 2/3 in total were Staph aureus of some sort. The other smaller fractions of the pie here were coag-negative staph, strep, and then the other category in dark blue. So with that in mind, we want to cover MRSA. So then, which antibiotic do we use? So for simple abscesses, again, like I mentioned, know your population, know your antibiogram, but you can see your MRSA specific antibiotics here. So oral MRSA, you can use that trimethoprim sulfamethoxazole, Bactrim, doxycycline. Next up, linezolid. And as you know, we're not big fans of clindamycin because of all the C. diff adverse events. And then the IV options for MRSA are there: vancomycin, daptomycin, linezolid can be PO or IV. If your patient or resident is known to have MSSA and not MRSA history, you may go straight to the MSSA antibiotics. And those would be cephalexin, dicloxacillin. IV options are oxacillin, nafcillin, and cefazolin. Again, if you don't know if the patient doesn't have a history or resident does not have a history of one particular Staph aureus, you want to opt for coverage for MRSA. So now let's go down the non-purulent cellulitis route. So with non-purulent skin and soft tissue infection, we're talking about our classic presentations of erythema, warmth, tenderness can present otherwise similar to MRSA, skin and soft tissue infections. The layer of skin that is involved is how these different names get their say. So impetigo is the very superficial layer. Ecthyma is where we're starting to get into the dermis. Erysipelas is where we have lymphatic involvement. And then, as you know, cellulitis is a catch-all. So we might call all of these cellulitis, but it also could matter is, do you have subcutaneous tissue involved? So for most of these, however, these are generally caused by strep, often group A strep, for which the treatment is penicillins or good old first generation cephalosporins. As you can see here, there's that picture, and these are gram-positive cocci in chains, indicating strep most often. So let's look at some examples. So non-purulent cellulitis, you can see in this example of one leg with erythema. If we were to touch it, it would probably be tender and warm. But you can see here, there's probably some spreading, but no pus involved. So these are most often caused by beta hemolytic streptococci. There's different groups of streps, as you see here, but group A strep or strep pyogenes is the most common. And then we also have group B, C, and G strep. Doesn't matter exactly in that if you are suspecting streps, same, you just need the first generation cephalosporins or penicillins. Again, the context of the patient, resident, their exposures, their history matters. That is going to be taken into consideration. If you have a resident who has multiple recurrent MRSA infections, you're going to probably want to treat with an MRSA antibiotic. Now, one question that sometimes comes up clinically is, do you need blood cultures to work up a resident with skin and soft tissue infection? And generally, the answer is no, unless you have these certain categories or context, again, contextual clues. For example, if someone's immunocompromised or receives chemotherapy, if there's an immersion injury, like a burn, if there's an unusual exposure, etc., then you may be getting blood cultures. But in general, the yield is less than 5%, and therefore it doesn't generally change management. So again, what are our anti-strep antibiotics? They're listed here. As I was saying, oral penicillins, also IV penicillins work just fine. Cephalexin is a go-to because it's easily tolerated and easily dosed. If you're going the IV route, we have cefazolin. Ceftriaxone is a bit overkill, but it does have good strep coverage. Ceftriaxone is a third generation, so we're also cephalosporin, so we're also getting a bunch of gram negatives, which are usually not necessary for cellulitis treatment. I just put in some examples here of some of these do still cover MSSA or the methicillin sensitive Staph aureus, such as cefazolin or first generation cephalosporins like cephalexin. And then our anti-MRSA, you can kind of ignore the last box here. It doesn't have an antibiotic listed, but if you're worried about MRSA, then we need to use our anti-MRSA drugs that I listed earlier. So importantly, and this is just probably going to generate lots of discussion, is all of the non-infectious mimickers that look like cellulitis. So the classic is quote unquote bilateral cellulitis, where you have symmetric involvement on both extremities, such as this example on the left, which is most often caused by stasis dermatitis. This is basically due to insufficient venous blood flow. So also very classic in those with heart failure. So when you don't have blood return and you have that pooling, it goes subcutaneous and you can have redness and so often a purple. And sometimes when it gets really bad, I'll see blisters form as well. Most importantly, if you see both legs involved, we have to address the underlying issue, which if it's our heart failure, do they need diuresis? But most commonly, the recommendation I give is to wrap these legs. They need compression and elevation, and that will often take care of the erythema. Some other non-infectious mimickers is a DVT or deep venous thrombosis, which can be one extremity and look just like a cellulitis. It can be red, warm, and tender. But the context again matters. Are they on blood thinners already or not? Do we need to get a duplex Doppler? That might be something your provider is thinking about. If someone is on warfarin, one uncommon but known adverse event is calciphylaxis, and that can cause that photo there on the top right. Also, drug eruptions or drug allergies can cause a cellulitis looking presentation. It can be blotchy though. It's hard to, may be hard to see that on that example, but there may be clues. It might be itchy, and that may be another clue. And then of course, gout. So if it's in these classic joints, like the first metatarsal of the lower extremity, you may always need to think about gout. So these can present and meet the Loeb criteria for cellulitis. So important to think about alternatives. Okay, and then we don't have a ton of time, but I wanted to acknowledge candidiasis. So this is a yeast, and this causes a beefy red coalescing papules, and they can form plaques and then white kind of chalky areas, and it's common in the skin folds. Candida is notorious for these satellite lesions, and that's where you see like the central erythema at the under the skin fold, and then you see these little red spots that are migrating out. Those are called the satellite lesions. Again, starts in those skin folds in moist environments. All ages get these, and someone who is hyperglycemic or has some underlying uncontrolled diabetes may be more predisposed to this. Diagnosis is clinical. You may see your providers prescribe topical nystatin or give doses of oral fluconazole. So as I was alluding to earlier, there are Loeb criteria for skin and soft tissue infections, and those are listed here. So you need to have one of the following criteria: either new or increasing purulent drainage, i.e. Staph aureus infection, or at least two of the following. And that's the classic redness, tenderness, warmth, new or increased swelling. And then often, but not always, there can be a temperature elevation, either above baseline or a frank fever. However, that's not super common if it's a smaller cellulitis or skin and soft tissue infection. As I mentioned before, there's plenty of non-infectious mimickers that can meet this criteria. So having an alternative diagnosis is helpful in determining if this is a true skin and soft tissue infection, but that is going to be up to your provider. And then there are McGeer criteria for skin and soft tissue infection as well. Similarly, need to have one criteria, either a pus or purulent wound, skin infection, or you need to have, in this case, they have 4 of the following criteria. Again, the heat or warmth, erythema, edema, tenderness. They may also have serous drainage, because as that infection that inflammation is happening, you can have this clear yellow drainage. And then systemically, if someone's getting to be septic, that's kind of where we're going with the bottom criteria here: fever, leukocytosis, altered mental status, and acute functional decline. Probably if we're hitting those, we're going to be going toward IV antibiotics and possibly a trip to the ED or a hospital. And then if a culture is obtained, again, it's really going to be most feasible if there is pus involved that can be expressed and cultured. Otherwise, we do not generally recommend swabbing the skin without infected fluid. So as it says here, positive superficial wound swab culture is not sufficient evidence to establish a wound infection. It is very likely, if you were to do one of these wound swabs, is that you're going to grow skin flora or organisms that the patient may have, a resident may have in a potential wound. So we do not recommend that routinely. And again, this is for As we've talked before, Loeb and McGeer. Loeb is for helping determine if a provider needs to start antibiotics, whereas McGeer is doing the look back and determining for surveillance purposes if a resident met criteria in retrospect. All right, so I'm going to turn it back over for a practical activity.